Hello everyone, and welcome back to another Rafael Medina subspecialty virtual morning report. Today, our focus will be on pulmonary critical care medicine, and for this we have two amazing guests. As a case discussant, we have Dr. Subani Chandra, who is an associate professor of medicine and pulmonary critical care medicine at Columbia University Medical Center, who serves as a program director for the internal medicine residency program and as the associate vice chair of education for the Department of Medicine. She is a dedicated clinician and educator with a special interest in the development and application of POCUS. She has leadership roles with the Training and Transitions Committee of the American College of Chest Physicians and the American Thoracic Society. In addition, she serves on the editorial board of the Chest Journal. And as a case presenter, we have Dr. Sangeetha, who is currently a resident physician at Columbia University Medical Center in New York, who got her medical degree from University of Washington in Seattle. She is originally from the Tri-Cities in Eastern Washington, did her undergrad at Georgia Tech in Atlanta, where she majored in biomedical engineering, and she hopes to pursue a fellowship in pulmonary critical care medicine following residency. And before we jump into the case, I would like to ask both of you why you chose pulmonary critical care medicine as a subspecialty and what you like to do outside of medicine.
I can go first. Hello, everyone. First of all, thank you for having me here. Why did I choose pulmonary critical care? I think probably for the reason that most people who choose pulmonary critical care choose pulmonary critical care. I think that some of the cases or the highest excitement that I had, though I loved everything in medicine, so I did go through that phase very much so, was really in the ICU. And I think what appealed to me most was that sort of you can have physiology and pathology and interventions and sort of really getting to assess the effect of those interventions pretty quickly. And I found that I could sort of start to conceptualize in my mind's eye, if you will, of what was actually going on inside each patient. And that was just a very exciting feeling. But I will say I do love all aspects of medicine, and pulmonary critical care is just where I happen to be. What do I like to do outside of medicine? I think I will say, I think I have the absolute best job in the world. I am the program director for some phenomenal residents. I think our residents are truly special. And so in some ways, that part of my brain never fully switches off. It's either in the forefront or it's in the back end. Same for my family. And I like doing things that are creative. So I bake some fancy cakes for my kids. I like creating things with my hands. We're in the middle of a renovation in our home right now. So lots of creativity happening there.
Amazing. And Sangeetha?
Hi, everyone. Thank you for having me. I'm excited to be here and hopefully presenting an interesting case for Dr. Chandra. I am interested in pulmonary and critical care medicine. Obviously, I have not done a fellowship yet, but I'm interested in it, I think, for a lot of the same reasons that Dr. Chandra said. I think one of the things that I love about it is I love the acuity. I love being in the ICU and kind of having to, think on your feet. I love that aspect of it. I also just really love the breadth of medicine and getting to see so much good physiology and getting to think about kind of all the different parts of the body, both how they work individually, but also how they connect with each other. So that's the main reason that I'm interested in pursuing that field. In terms of what I like to do outside of medicine, I love being outside. So anything that involves being outdoors, whether it's running, hiking, going to the beach, going to the park. I love being outside.
Amazing. Then I would ask our scribe, Jimena, to share the screen with us, please.
Thank you. Just give me 1 second. There it is.
Thank you so much. And Sangeetha, whenever you feel ready, you can please start with the first aliquot.
Yeah, I'd love to. Okay, so this is a case of a 50-year-old woman who presents with productive cough, fatigue, and fevers. 3 weeks prior to presentation, she notes that she developed fevers, a slight cough, and some fatigue. This lasted a couple of days, and then she notes that her symptoms actually got better. However, she then notes that like about a week later, her symptoms got worse again. And she had a worsened kind of productive cough, and with some yellow sputum, and also had kind of associated fevers and this new left-sided chest pain. And I'll pause there.
Okay, so we see we have as a chief complaint productive cough, fatigue, fever, and seeing that the fever or generally the symptoms started 3 weeks ago. So seeing these symptoms, what do you think of as a first impression, Dr. Subani?
Yeah, so I think initially with the chief complaint, productive cough, fever, fatigue, it's a very classic story for an infection, pneumonia. We don't know much about our patient yet as to what their medical history has been and all of that. That certainly influences that. But some sort of infectious or inflammatory condition would be the first thing that comes to mind. And Shima, like you were starting to allude to, 3 weeks, though, is a slightly long time for typical community-acquired pneumonia. And we also heard the story of she had a couple of days of symptoms, then it got better, but then it got worse again. So perhaps either a vaccine waning course or something superimposed on something. So those are some of the things that come to mind. But I think currently, based on what Sangeetha has told us, some inflammatory and or infectious process, whether that be truly infection or vasculitis or some sort of rheumatologic, eosinophilic, that whole category.
Thank you so much. And with the timeline of 3 weeks, when you think of infectious processes, are there like bugs or agents that you think of typically?
Yeah, great question. So one of the common patterns we see in the pulmonary clinic or in the hospital in patients who present with symptoms like this is that maybe they had a little bit of a viral infection, a viral syndrome, that spontaneously gets better, and then they develop a superimposed bacterial infection. So they either start to get better and then worsen again, or they never fully get better and start to worsen, or they develop some sort of complication or residual infection. So whether it be that they've developed a sinusitis or a bacterial infection superimposed, something like that, sort of that bimodal distribution comes to mind. It's possible, by chance that the two are true unrelated, but as we know, that's less likely in medicine.
Thanks for all these pearls. Then Sangeetha, would you like to give us more information, please?
Yeah, sure. So she actually was originally seen, she went to an urgent care with her symptoms, and I think she had some exam findings that were concerning for possible pneumonia or some kind of infection. She said that she didn't have a chest x-ray done, and we actually didn't have access to her kind of like outside urgent care chart. But they decided to treat empirically for possible CAP with like a Z-Pak with azithromycin. So she says that she took those medications and had no improvement in her symptoms. She notes that she had kind of persistent cough for 2 more weeks, increasing fatigue. She's normally at baseline a very active person. She goes to the gym multiple days a week. She's able to walk several miles, no real kind of like exercise intolerance, but notes that she had noted kind of increasing fatigue and wasn't able to do those normal things. And also notes kind of worsening left-sided chest pain that she had also noted before. She also describes this feeling of shortness of breath that she actually described as kind of being unable to take a deep breath. No hemoptysis, no recent fevers in the week leading up to presentation, actually. She ended up going to her PMD and had some imaging done, which we'll get into, and then eventually presented to the ED.
Thank you so much. So what I see new from information is basically that she's worsening in her symptoms despite taking antibiotics. So Dr. Subani, what do you think of this whole process right now?
Yeah, and just to summarize, to make sure I got the timeline correctly. So 3 weeks ago, our patient had cough, fatigue, and fever that resolved or didn't maybe fully resolve, sort of got better after a couple of days with no specific treatment. And then a week after that, she started to feel worse again and had a productive cough, left-sided chest pain, but no fever that did not respond to azithromycin.
That's correct.
Thanks. Yeah, so very interesting, and I definitely want to know more about our patient because that does sort of influence what the possibilities may be. For example, if she has COPD or intravenous drug use or significant alcohol intake history, all of those things, or a history of HIV or some sort of immune compromise, that will sort of shift or at least my thinking a little bit. But this is somebody who I'm concerned about because they are failing outpatient antibiotics. So either they have a process, if it's infectious, then it is something that is not sensitive to or responsive to azithromycin, or they have something entirely different that can mimic sort of pneumonia, but does not typically respond to antibiotics. So that could be something like organizing pneumonia, or again, some sort of inflammatory rheumatologic condition. So those are some of the things to look out for, but I am increasingly concerned about her. And then the left-sided chest pain, obviously left-sided chest pain, you have to think about cardiac as well as pulmonary, but would love to know if it's pleuritic. Is it always there? What makes it worse? Is it exertional? Is it non-exertional? And things like that, and looking for cardiac causes, pulmonary pleural causes, and vascular causes for that.
Thank you so much for all these pearls. Then Sangeetha, would you like to give us the next aliquot, please?
Yeah, sure. And I can give a little bit more history that I held on to a little bit, and then I'll go into her past medical history. So she actually, like a few days prior to presentation, she went to her PMD and had a chest x-ray done, which we can take a look at, but was essentially started on 30 milligrams of prednisone and Augmentin daily, and was ordered for a CT scan and for follow-up with a pulmonologist. Following initiation of the Augmentin, she actually noted that her cough improved, and the cough became unproductive. So she still had this persistent dry cough, but her symptoms overall were getting better. And then she went to the pulmonologist, had the CT scan done, and we'll talk more about that. But with regards to her past medical history, so she actually has a history of post-infectious bronchiectasis as a child, and status post a left upper lobe resection at the age of 12. Since then, she notes that she actually hasn't had any significant respiratory problems, has had kind of like occasional colds, maybe occasionally had gotten a Z-Pack at like an urgent care, but never been hospitalized, never intubated, never required any like supplemental oxygen. She also has a history of hypertension. In terms of her home medications, she's on amlodipine 5 milligrams, nebivolol 10 milligrams, and an estrogen patch. Social history for her. So she works as a teacher and a writer. She has 2 children. She doesn't have any smoking history. She drinks socially, maybe 1 drink a week. No recent travel, no pets. The only thing she kind of noted was that she'd gone to the dentist 1 month prior to her initial symptoms, and no allergies to any medications. I'll pause there.
Yeah, that's a lot to unpack. So she has this history, if I understood you correctly, of sort of post-infectious focal bronchiectasis that was resected in the left upper lobe. Yeah,
that's correct. Yes.
Okay. And do we know if she was at that time worked up further, or you mentioned she's had colds in between, but recurrent sinopulmonary infections or something like that would indicate an underlying immune deficiency potentially? And if it was focal bronchiectasis that was resected in the left upper lobe after lung destruction from presumably a bad infection of some sort in childhood, then she really should not have lingering sort of some of the classic bronchiectasis symptoms that we think of, which, you know, certainly for exacerbation, the key thing is that they get recurrent infections. And so presentation with recurrent infections and a chronic cough would be common, but it seems like our patient has neither of those. And so I think, and you had mentioned that she had a chest x-ray and subsequently was started on oral steroids and Augmentin, which is amoxicillin clavulanate, and is feeling better. Do we know if she reports a history of wheezing, or you had mentioned no hemoptysis, and both the steroid and the antibiotic were started together, is that right? So we can't tell which one had the effect, because, for example, with left-sided chest pain, if she has an inflammatory condition such as, let's say, lupus that is causing a pericarditis or pleuritis, she may start to feel better because of the anti-inflammatory effect of steroids unrelated to the antibiotics per se.
Thanks so much for all these pearls, Dr. Subani. Then Sangeetha, would you like to share the next aliquot with us?
Yes, and I can answer a few of those questions that you had. So with regards to her bronchiectasis history, we don't have anything kind of in our charts. It's all based on kind of what she was able to recount for us. But she told us that she was kind of worked up for any immunodeficiencies, worked up for possible cystic fibrosis as a child, and that was all negative. So my understanding is that they did think that it was probably just focal bronchiectasis. And then you had asked if she'd had any wheezing, and she did not know any wheezing to us. Okay, so I can go into the next part of the case and talk a little bit about her actual kind of ED presentation. So her physical exam when she arrived, her vital signs, she was afebrile on arrival, although notably she did spike a fever on the second day of admission. She was tachycardic to 111. Her blood pressure was 130/87, and she was satting 96% on room air. Her physical exam was pretty unremarkable. Her general exam, she's very well appearing. She's thin, but very pleasant. Her HEAT exam, she had moist mucous membranes. Cardiovascular exam, she was regular rate and rhythm, no murmurs, no lower extremity edema. Her pulmonary exam, she was breathing comfortably on room air, no respiratory distress. She did have decreased breath sounds in the left, mid, and lower lung compared to the right. But otherwise, like no wheezing, no crackles on her pulmonary exam. And then the rest of her exam was very unremarkable. In terms of initial labs, so her white blood cell count was 38. Her hemoglobin was 12. Platelet was 422. The differential on the white blood cell count was 83% segmented neutrophils, normal bands, 10% lymphocytes, and she had 3% EOs on that. Her BMP was completely unremarkable, really nothing noteworthy. And then she had a CRP checked, which was 208. She had an LDH check, which was 481. And then her initial RPP was negative.
All right, so a lot of information here. Just to maybe start with the physical exam. So she's a little tachycardic, and she's not necessarily overtly hypoxemic. She's 96% breathing room air. You didn't mention a respiratory rate, and you did say that she looks comfortable. So I assume there's no sort of respiratory distress, no use of accessory muscles. The pain in the left chest is not so bad that she looks uncomfortable. Is that accurate?
Yes, that's accurate. Her respiratory rate was normal.
Okay. And so a few things that I think of when I'm thinking, especially in the infectious inflammatory category on physical exam to look out for. So certainly sort of a sinus exam, for example, if there's tenderness or anything like that over the sinuses, it's good practice usually to look in the nose, because even though we don't get a history of epistaxis, many vasculitides, you may get sort of nasal ulcers, or they may be dry, crusty blood in the nose, and the patient didn't think to mention that as anything that is different or unusual. So that's very helpful sometimes as well. Sometimes patients don't have epistaxis that's visible and the blood sort of drips backward, or certainly patients can have alveolar hemorrhage or diffuse alveolar hemorrhage without having hemoptysis or epistaxis. So in as many clues as we can get on exam is one of the things that I always look for. So looking in the nose, looking in the mouth. When I look in the mouth, also looking at the teeth. You'd mentioned that she went to a dentist. I don't know what that was for, or maybe, if she has poor dentition or dental abscesses or something like that. Those are known risk factors for aspiration pneumonia or lung abscesses. And lung abscesses can sometimes present like this a little bit, sometimes even over a longer duration than 3 weeks. They're sort of indolent, and the patient usually feels fatigue. There may be fevers, there may be cough, and just sort of progressively just not feeling 100% and getting worse. So, and then on the chest exam, the heart and lung exam, decreased lung sounds on the left lower chest wall, I presume, and I think you'd mentioned she's had a left upper lobectomy in childhood. So that obviously points to potentially something's going on, because even with the left upper lobectomy, I would expect that the left lower lobe sort of has expanded to fill the majority of the space. So I wouldn't necessarily expect decreased breath sounds on the left. And I know that we always talk about sort of percussion and E2A changes and bronchial breath sounds, and you didn't mention any of those. So I assume that those were either, those are perhaps not done, as is unfortunately not uncommon, I think, everywhere. But for example, E2A changes, when you ask the patient to say, the letter E, and when you auscultate if it sounds like A, that usually indicates that there is dense consolidation, or something like that. So those would be some of the things to look out for. I would also be curious about making sure I check for things like clubbing, if she does have underlying bronchiectasis or some chronic pulmonary problem. Those kinds, clubbing can be a clue, though the absence of clubbing certainly does not exclude that. And then looking at her labs, she certainly has a leukocytosis and it's neutrophilic predominance. So that again sort of pushes us in this direction of maybe something infectious is going on here. Her CRP is very high as well. Her RPP is negative. COVID, I don't know what time of year or what year even we're in this case. So certainly checking for COVID, and does the RPP, the respiratory PCR, include an influenza PCR? Because the story of a little bit of something got better and then got worse again would not be atypical for influenza followed by a bacterial infection, or COVID followed by a bacterial infection, or any viral infection followed by a bacterial infection.
Thanks a lot. And another question that that now came up to me is seeing the CRP is being elevated and the LDH is being elevated. How would you explain the high LDH in this case?
So, inflammatory markers can be elevated for so many reasons, and so they're fairly non-specific. So I think in this instance, specifically for diagnosis, in my mind, they are less helpful than the white blood cell count, the neutrophilic predominance, and things like that. Occasionally, depending on what the final diagnosis ends up being, sometimes we may track those markers. And if this patient ends up having an effusion, then perhaps having the serum LDH that you wanted simultaneously can help diagnose transudate, exudate, though if this patient, we can talk about that if that's the route we end up going in.
And another question is, as you mentioned, the poor dentition predisposing for something like aspiration. When we think of something like aspiration pneumonia, what kind of bacteria or infective agents do you typically think of?
Yeah, great question. So aspiration pneumonia, often the things that I worry about is that it can be polymicrobial and then anaerobes. Those are the two big things to keep in mind. So if there are any risk factors, and the risk factors that make me think of aspiration pneumonia, so one we mentioned, somebody's had a dental procedure or even a bronchoscopy, endoscopy, they've had sedation, those kinds of things would predispose. Or if they use enough alcohol or other drugs that they may frequently not be fully alert, or things like that, or if they do have some sort of dysphagia or achalasia or esophageal dysmotility, things that would predispose. Or if they're in the ICU and they got intubated, or they're vomiting, things like that, then aspiration sort of rises to the top. We often talk about aspiration pneumonitis versus aspiration pneumonia. So pneumonitis being sort of a chemical reaction, it can make patients appear quite sick with an intense inflammatory reaction, sometimes a mild one in the lungs, and then it typically gets better fairly quickly. And sometimes that aspiration can cause infection or pneumonia, and then, like I mentioned, anaerobes, especially oral anaerobes, and to remember that it can be polymicrobial.
Thank you. And in this case, would a procalcitonin be useful?
Interesting question. So I think procalcitonin certainly come into use a lot. I'm sure many of you, all of you, talk about it in a lot of patients. So I think that as the data shows, for initial diagnosis of a pneumonia, I don't think it is very useful. It is sometimes helpful to check, because what we do, at least in our institution, is we check about every other day or every 2 days, sort of to get a trend. And its utility is primarily as an adjunct in trying to make the decision of when to stop antibiotics. So if the procalcitonin, if the patient's clinically improving and you're sort of thinking, should I do 5 days of antibiotics or 7 days of antibiotics or 10 days of antibiotics, for example, then a procalcitonin level may be another piece of evidence in addition to how the patient is doing clinically in helping you make that decision. So if the procalcitonin trends down to less than 0.5, I think, or it drops by 80% or more from the initial peak level, then those support that you can safely stop antibiotics in that patient. So in this instance, at this moment, it does not help, in my opinion, specifically, but may still be useful to get for later.
Thank you so much. And Sangeetha, would you like to please share? Would you like to share the next aliquot with us?
Yes, I would love to. So I think we're at the moment where we should probably look at some imaging. So I will share my screen if I can figure out how. Okay, can you all see my screen okay?
Yes.
Okay, great. So we can start with the chest x-ray. And maybe I could just go through and kind of give my interpretation of it, and then Dr. Chandra, please feel free to add in any things that you notice. So just starting with like ABCD, starting with the airway, it appears to be midline to me. She has kind of good lung volumes, especially on the right side. Looking at her cardiac silhouette, very difficult really for me to tell kind of where her cardiac silhouette is. I suspect it's like right here based on this outline, and I suspect that this is maybe her left middle to left upper lobe potentially. And then kind of going through, looking at our diaphragm. So the right costophrenic angle is very sharp. I don't see any kind of evidence of effusion. The left costophrenic angle, I really can't see. And so I'm concerned that there is some kind of effusion along with a very kind of potentially large consolidated process in her entire kind of like left lobe, primarily middle, I think, looking at, I mean, I can see a little bit of upper, but Dr. Chandra, what do you think?
Yeah, no, I agree. So obviously our eye goes right away to the left hemithorax because there seems to be a lot going on there. And thank you for mentioning sort of ABCD. Yeah, for whatever algorithm you all, I always say, find a system that works for you, whatever that system is, and go through everything systematically, because particularly cases like this is where you may miss a fracture. So for example, this patient could, while this is not the best way to diagnose this with that caveat, this patient could have a rib fracture. She's been coughing for a while, and a rib fracture may explain, for example, left-sided chest pain. So typically we would need a rib series, but sometimes we pick those up on a regular chest x-ray, for example. It's a little bit hard for me to definitively say exactly what's going on in the left chest. So we obviously see that there are opacities there, and there is almost this lucency in the middle, right, where Sangeetha, you said sort of the heart shadow would be. So I'm not sure, and I can't make out the diaphragm also, though I do make out bowel right below. So it does seem like there's an elevated diaphragm potentially on that side, which in of itself may not be unexpected for her because you told me she's had a left upper lobectomy. But the degree of opacity I don't see clear air bronchograms makes me concerned that this is something in the pleura, and that if so, it is potentially a loculated effusion because it seems to be defying gravity. I think the caveat being that her anatomy may be a little bit different from typical because she has had one of her two lobes removed. I see sort of these, I don't know if it's a meniscus. The lucency in the middle is throwing me off a little bit. I'm really curious. I sort of want to ultrasound this. And the left apex, I can't tell if there are lung markings there. To my eye on this screen right now, it seems like there may not be. And the other thing notably is that I don't in this X-ray see any clear evidence of bronchiectasis otherwise. At first glance, it seemed like maybe she's slightly hyperinflated, but I think I count just about 8 posterior ribs, so perhaps not, but that would be also informative since we do have that history in our patient. Very interesting thought. I want to look at it more.
All right, well, we'll get to the CT scan, and I can kind of go through like the official read. So, well, maybe we can look at the CT scan first, and then I'll talk about the official read. So, this will just like play through. Hopefully it's slow enough, and we can pause wherever. I can let it play a few times. But this is her CT scan. So we can run through it again. So right here, what stands out to me is that she has kind of this opacification here. That this is on lung view, but I think if I looked on abdomen view, it would look like fluid. And then interestingly, she also has like a little bit of air right here. And if you keep going up and you can see like you had mentioned, it's kind of like septated, which makes me think that it is like loculated. And then if you continue going up, you can see that she kind of has more air up near kind of the anterior portion.
Yeah, I 100% agree. And I don't know if you have the mediastinal windows, but a few sort of classic things, if you will, and that's a great place to pause. So what we see is that there is an opacity in the left chest, which it appears is longer than it is wider. And I mention that only because a classic teaching, there are always exceptions, is that that is one of the hallmarks of when an opacity is pleural based. So sometimes when you see an opacity and you're not sure, is it in the parenchyma, is it in the pleura, pleural opacities tend to be longer than they are wider inside, perhaps because they spread along the pleura. So I think that's one thing that stands out. Two, obviously, an effusion that defies gravity by definition then is loculated because it's magically hanging in an anti-gravity form. Interestingly, CT is not good at showing loculations themselves. It is very good at showing fluid exactly like this, that it must be loculated, but to actually see the septae is very unusual in CT. Meanwhile, ultrasound shows those beautifully. So CT overall is more sensitive to detect pleural effusions. Among the 3 modalities, X-ray, ultrasound, CT is the most sensitive. The ultrasound is pretty close. But ultrasound shows one thing better for sure, which is septations. The other very classic thing that here stands out to me is that air fluid level, right? It's a straight line. There's not too many things in nature that give you a straight line. And so anytime I see a straight line, I think of an air fluid level. And then air, so this is essentially a hydropneumothorax. And air in the pleural space can only come from a few sources, right? So either air that was within the lung escaped into the pleural space, that's a classic pneumothorax or a hydropneumothorax, or air was introduced from outside. So we caused a pneumothorax, or the patient was had some sort of trauma that penetrated the chest wall and introduced air from outside. Those are the two that we most frequently think of. but sometimes air can be in a pleural space because there's an organism, an infection that produces air. So anaerobic organisms that often are sort of gas producing organisms that can be the sort of third source of air in the pleural space, if you will. And certainly sometimes it can track up, I should say, from those extremes, from pneumoperitoneum or something like that. So it narrows perhaps our differential a little bit of what may be going on here. And seeing this, I would really want to know more about what was that dental procedure, what really, because as we were saying, aspiration, lung abscess, a lung abscess that's been festering can just sort of erode into or melt into, if you will, the pleural space and look a lot like this. So any of those things, or necrotizing pneumonia, all of those things are possible.
Thanks a lot for all these pearls. Another question that I was going to ask, as you mentioned, like this longer than wider is speaking more for a pleural process. Is there anything else that helps you, for example, to differentiate whether this is a peripheral pulmonary abscess versus something like an empyema that could be going on?
So you mean like whether this is in the parenchyma of the lung itself or like a pleural empyema? I think if we are able to see the mediastinal windows, that would help a lot, but this is something that goes all the way to the chest wall, is not sort of in the center. I don't see a clear abscess. Abscesses usually will appear, some version of round or cavitary like, and this just looks like this fills a good part of the pleural space. And then we also see sort of lung, and there's a sharp border between what is the black lung and then this white sort of opacity. So that also sort of makes me think that this is in the pleural space. And the other thing that we didn't mention, right in this where you have paused, you can see actually some bronchiectasis on the right side. You see, and then if you go above that, you see these sort of airways with these two parallel lines. Sometimes those are called tram tracks. So basically dilated airways that fail to taper as they go further distally is a classic appearance of bronchiectasis. And this image is fairly small, but it's sort of, I can convince myself that maybe there's a little bit of nodularity right in the right anterior lung, maybe even a tree and bud, might I suggest, which basically looks like, these branches that end in those little round nodules or dots. That's where the name comes from, tree and bud. I think every year in March, I see so many trees and bud, and I have so many photos on my phone because I keep saving them to say, everybody just have that visual. It's really classic that way. Tree and bud, I should say, because it gets invoked a lot of times, and it's sort of, linked with TB, if you will. And certainly TB can do that, but it's usually indicative of something that is an airborne infection, is the broader way to think of it. So putting all of this together, this seems to me to be somebody who has some bronchiectasis, even though we got this history of focal bronchiectasis, and she does not have a typical history of frequent exacerbations, and who very likely has an infectious process and pneumonia in her lung, and sort of, I would say, non-resolving pneumonia, potentially due to this pleural effusion, which could be an empyema or a complicated pneumonic effusion. And I would be worried about anaerobic and polymicrobial etiology given the hydropneumothorax. But yeah, if I would love to hear more about this dental procedure.
Yeah, so in terms of the dental procedure, she told us that she had a deep cleaning, which is what she described as. but didn't have like any teeth taken out, no like root canal or anything like that, but deep cleaning. And then Dr. Chandra, you could have been the radiologist who read this. The formal read showed just like a large loculated left hydropneumothorax, along with tree and bud nodules in the right middle and right lower lobe, and bronchiectasis within the right middle lobe and upper lobe as well. So that was kind of the final read on that. I can stop sharing. Where's the button to stop sharing? Oh, pause share. Did it stop? Okay. All right. So I can give you a little bit more information at this point in terms of kind of what happened with her. So given this large loculated left hydropneumothorax, we decided to place a chest tube. And so she had a chest tube placed and was set up to suction. In terms of the pleural fluid studies, so I can kind of tell you what those showed. So her pH of the pleural fluid was less than 6.82. The cell count was 156,000 total nucleated cells, with 99% segmented neutrophils and 63 red blood cells. The adenosine deaminase was 577. Protein was 0.8. Cholesterol was 27. Triglycerides was 64. Glucose was less than 5, and her LDH was greater than 5,000. And then the cytology showed many inflammatory cells, mainly neutrophils. And I know we're getting close to time, well, somewhat close to time, but the pleural fluid grew strep anginosis.
Very interesting. Again, so much to talk about there. So I think interesting move to put in a chest tube right away, right? Because typically, I'm sure many people are wondering, we sample the effusion. So a few things. So an effusion like this, which is a paramnemonic, is our leading differential. We should do a few things very quickly. So we start antibiotics as soon as possible. Ideally, before we start antibiotics, we would try to send cultures, sputum cultures, blood cultures in this instance, because she's clearly has some sort of complicated infection. But obviously we don't wait for those results. We have to act on this quickly. And while we would typically, I would probably say that I think the most common approach would be you set up for a pigtail, a small bore chest tube, anticipating that you'll need to drain this because if it is paramnemonic, it is presumably at least complicated paramnemonic. And so you can sample and be ready to place the chest tube at the same time, which is sort of, I'm sure, what you all did. So paramnemonic effusions can come in three varieties, if you will. So simple paramnemonic, which is typically free-flowing. They're all exudative, but a simple paramnemonic is just sort of, I think of it conceptually as everything is inflamed, and so fluid is leaking out, but the fluid is not actively infected. It is not inflammatory. So you get a fairly simple appearing effusion and an effusion that is free-flowing. Once the inflammation in that space starts to get worse, that's when you start to see things in the effusion. So sometimes on ultrasound, we may see what sometimes is called a plankton sign, like little things floating around, or that's when you start to see septations and loculations come in. And as that process goes on, that can turn into pus, which is empyema. So when we sample the pleural fluid or drain the pleural fluid, the easiest thing to diagnose is an empyema, because if it looks like pus, it's an empyema. You don't need any lab tests or any other tests. And sometimes you can tell by smell, especially an anaerobic empyema can have a pretty unpleasant a smell to it, but usually it looks really nasty, and that's your diagnosis. For a complicated parapneumonic effusion, in addition to all these loculations and all, your patient has a lot of those. So the pH is low here. A word of caution on that, because it really depends on how your hospital or clinic runs these and how you send the sample. You never send it in the syringe that you did the lidocaine with, because that can artificially decrease the pH. It's often sent in an ABG syringe, and that is typically lined with lithium heparin, and that can artificially decrease the pH as well. If there is some air in that ABG syringe, it can sometimes increase the pH, and if the fluid sits for a long time before it's analyzed, that can affect the pH also. But this 6.8 seems quite acidemic and consistent with our story. It is very cellular, highly neutrophilic, and the glucose here is extremely low. And so this very consistent with at least a complicated pneumonic effusion. So you didn't tell us what it looked like when it came out, but that is one of the first things I look for. And then you gave us the culture, so that sort of clinches our diagnosis. Strep anginosus is actually not uncommon in this scenario. It is a strep viridans, and most empyemas, if you will. Strep pneumo is perhaps the most common, or one of the most common at least. But then the viridans, the Milleri group, are some of the most common. So I think anginosus intermedius constellatus, I want to say, are some of the things like Legionella, and all seen it. The one beautiful salient point here is that you acted quickly, because this is not an effusion that you sit on and you say, oh, we'll do it tomorrow, or, you know, this is, you sample as soon as possible. So well done.
Thanks for all these pearls. Another question that came up, as you mentioned, the strep anginosus being like part of the normal oral cavity. Do you think that the stental procedure was like the cause, that strep anginosus is like the cause for this empyema here?
I don't know, but you know, I think that it's consistent. So strep anginosus is part of oral flora and highly associated with sort of aspiration. It has a tendency to form abscesses. So this could have been, for example, a lung abscess that slowly sort of, in my mind's eye, I see it as just, you know, a necrotizing pneumonia that literally just melts into the pleural space. And I think that's a very plausible theory here, because there's certainly a temporal association.
Thanks a lot. And another thing that was a bit curious to me, the ADA being high. Like usually when I think of determining ADA, I think of like for diagnosis of something like TB. But I've also heard that ADA can also be like sometimes falsely be high or low if there are like some other conditions like HIV, or that's why I wanted to ask you why ADA was like determined here and why it is high.
Yeah, I don't know why it was sent, perhaps because they were being comprehensive, but you're exactly right that it's used most accurately and most frequently to rule out TB. So if the ADA is less than 40 or 60, then it makes TB extremely unlikely. And just like, you know, real life, in some ways, this fluid is very consistent with the clinical picture that we're seeing, in that it is acidemic, neutrophilic, with a very low glucose. They interestingly also checked cholesterol, which is 27. And we used to rely entirely on Light's criteria. And I should say used to carefully, because we still rely on Light's criteria to diagnose whether something is an exudate. And I think we all learned this in medical school of what is the fluid to serum protein, if it is greater than 0.5, or if the LDH fluid to serum greater than 0.6, or LDH in the fluid greater than 2/3 the upper limit of normal in the serum. Any of those criteria make this an exudate. We knew this was going to be an exudate before we get any of those values, because this is a loculated effusion, there's inflammation, it's going to be an exudate. But there is an increasing sort of move towards using fluid-only criteria, because this way you don't have to get simultaneous serum levels. So the most frequently used one is sort of called the PFO3, or pleural fluid only, and it's 3 criteria, and the criteria include cholesterol. So if the fluid cholesterol is greater than 40, I think, though there's, I believe, a PFO2 criteria where it's greater than 55. So there's a little bit of controversy, but an elevated cholesterol is one of the things that can classify an effusion as being an exudate. And here we see that it's lower. So I think it's a good reminder that not everything exactly always falls into the perfect place, but there are enough clues that when they sort of still fit together, and there is a pretty clear picture, even if everything is not exactly that.
Thank you so much for this, especially with this pleural fluid only free test combination PFO3. Like, I was also always thinking of these Light criteria, and seeing this is like also a huge learning point for me, and also for so many others, I think. And then I would ask you, Sangeetha, what was like the further process of this case?
Yes, so I can fill in a few of the gaps from before. So her respiratory culture ended up growing. It had like neutrophils and GPCs in pairs, and some like GNRs actually, but the GNRs never speciated. And then she had blood cultures drawn that were negative. And in terms of kind of how it progressed, so she was started on IV vancomycin when she was first admitted. And after the chest tube was placed, she had about a total of 1.5 liters drainage, and it was pretty purulent. It was very pus-like when it first came, and there was a terrible odor. So it was very much consistent with kind of a very bad like bacterial infection. And then following that, she actually ended up getting intrapleural thrombolytics for 3 days in order to help with kind of the loculations and help with the fluid drainage. And following that, infectious disease was consulted, and they actually did think that the dental procedure could potentially have been where she kind of like seeded the bacteria originally. And they recommended continuing Zosyn for while she was inpatient, and then doing Augmentin for like a 4 to 6 week course, and repeating the CT scan at that time. She had a repeat CT scan in the hospital as well, after the chest tube was placed prior to it being removed, and it showed significant improvement. And she is currently at home. I think she's still taking the Augmentin, and she's still pending her kind of last follow-up chest CT, but overall doing much better.
Thanks a lot. And Dr. Subani, what are first of all, your comments on this case so far?
I think a very nice, in many ways, a classic case of perhaps complication of a dental procedure in somebody with some degree of structural lung disease underlying, and a lovely case of sort of non-resolving pneumonia. We didn't specifically label it that initially, but non-resolving pneumonia, you have to think about a few specific things, and pneumonia should typically, at least patients that start to feel significantly better in 48 to 72 hours. even if markers, and as we all know, radiographic resolution may take way, way longer. And if they're not doing that, then you have to reassess. And one of the most common causes is that they have now developed a problem, a complication of the pneumonia for which antibiotics alone are not enough. So empyema being the most common one. Other things include like whatever antibiotic you're giving either does not treat that organism because that organism is resistant, or it's TB or a fungal organism or a viral organism, something that is not covered by that antibiotic. Host factors also come into play. So if your host is has low immunity or significant structural lung disease, things like that can prevent an infection from getting better in a timely manner. And then the last thing to remember for non-resolving pneumonia is that maybe it's not pneumonia at all. You know, when we started out, anything inflammatory could do this, and that's a whole big category, as everyone knows, of possibilities there.
Thank you so much. And Sangeetha, do you have any final remarks for this case? If not, I would leave the mic to Dr. Subani for her favorite teaching points from this session.
Yeah, I don't think I have any specific remarks. I think this was like a great case for me to learn from. I never even heard of a hydropneumothorax before. So yeah.
And thank you so much for being here. It was such an amazing case and also amazing discussion. We learned so much, and we also hope to see you again here. Then Dr. Subani, I will leave the mic to you for the teaching points.
Thank you, Shima. And like I see that we are on the hour, so there's lots of teaching points, but I would say one, get a great history. That history of dental procedure is really helpful. When you think about non-resolving pneumonia, think about host factors, structural lung disease, immunity, think about organism factors, resistant organisms, unusual organisms, and think about complications of pneumonia that are not treated by antibiotics alone. And when you see an effusion, certainly a loculated one, or even a non-loculated, left-sided effusion or left greater than right is not typical for volume overload or just pulmonary edema. So, one of the big teaching things always look at a left-sided effusion with suspicion and do some sort of diagnostic procedure to figure out what it is and drain an empyema or a complicated pneumonic effusion as soon as possible. And keep a close eye on your patient. If they're not getting better, then they may need surgery or other ways of managing the effusion.
Thank you so much for all these teaching pearls. And then again, thanks for being here. And we also hope to see you again here. And then I would end the session, and I'm wishing you all an amazing week. And bye, everyone.
Thank you so much. Thank you for having me.
Thank you. Have a good night.
Bye.